I'll try to avoid the repetition. I am Dr. Veronica Nyakato from pathology, and I'm in year 2 with a special interest in neuropathology. So soon you will see a publication about dementia at autopsy. Yes, so basically what is the role of a pathologist here? Commonly in Uganda we have not utilized our pathologists, and I'm glad to introduce to you our neuropathologist, who is Dr. Geraldine Wall. She's always around, so feel free to consult her. The main challenge is that with dementia, with whichever type of dementia you have, we have to confirm it with autopsy. So when we are talking about the prevalence of dementia in 30, you realize that many studies done from the UK, from the US, Japan, they have revealed that the prevalence goes low to up to 3% when you do autopsy. So maybe I'll agree with Dr. Nyakato where we say that for some patients we have diagnosed dementia when they are not demented. So, but with pathology we basically classify them. We classify them depending on the substrates, the neuropathologic substrates that we find when we analyze these brain specimens. But of course these substrates are proportional to the genetic risk factors, the environmental risk factors. So what are we talking about? We are talking about accumulation of amyloid beta for patients who have Alzheimer disease. And then we are talking about the tau protein. When as we read more, we realize that these are natural proteins that help us to function normally. However, in the Parkinson's disease dementia, where we have the Lewy body dementia, it is more with alpha-synuclein that has the abnormality. So you either have the gene that encodes for those proteins, or there is an abnormality in how these proteins will function. So for us, what would we do? We basically do what we call a full postmortem examination. Yes. What is our interest? So with this full postmortem examination, we are not looking at the brain alone. We are also looking at the CVS, we are looking at the CNS, because we have talked about vascular dementia, like in our patient. How do you confirm it? Because it will present as Alzheimer disease. You must do that autopsy. These patients die of comorbidities like pneumonia. It's among the commonest that has been found. So when we do this postmortem exam, we also help you to confirm your epidemiological data. So instead of saying everyone is demented when they're above 65, here you have to confirm. And then we also use these postmortems to audit our clinicians to see, did we really treat this patient well? Did we give them the appropriate? But in that we also guide them on further management of the patients that they are caring for. We also use these postmortems as a guide for family risk assessments. For us who are interested in dementia, we know that there's what we call early onset dementia. This will present in a vague way that for most of our the youth in their 30s, in their 40s, in their 50s, people will think that they are just having witchcraft coming to them. They will even think they're just stressed with whatever they are going through, but they are getting dementia. How do you see this? Because there is a genetic predisposition. So with autopsy, you will actually find this substress happening. So we also use this to educate further the other upcoming the medics, like we have our students here. How do we train them how dementia will present. How about the pathologies? For us, we use it a lot because it will help us to guide further, even on the medications that you can prefer, even on further investigations that can happen. So, as we go on, my main interest will be to show you what we really see when we have seen these patients. So basically for us in pathology, we want to classify them according to the features that we see. So macroscopically, if we talked about Alzheimer's disease, we will see the brain atrophied. So when we pick up this brain, that is what we see. And when we are looking at Parkinson's disease, when there's Lewy body dementia, you will see commonly it is the substantia nigra that is pale compared to the norm. I'm going to show you a diagram of this. But then in many of these patients, we have a compensatory hydrocephalus. And of course, for the people with Alzheimer, when we look at our microscopes, we are interested in what they call the plaques and neurofibril tangles. And with the Parkinson, we see the Lewy bodies, and it's also what we call the Lewy neuritis. With histochemistry, in our diagnosis, we do not just pick up the brain and we end there. When we have seen in the microscope, we want to confirm, because when you will realize that there are many diseases that can cause the atrophy, that can present with the same substrates. But how do you differentiate them from Alzheimer's? So when we do a Congo red, we are interested in seeing the amyloid beta, amyloid depositions in our vessels. And when we do the silver staining, we are interested in demonstrating the tangles. So, and because Parkinson's disease and Lewy body disease, in its pathogenesis, there's also a link to the tauopathies. It may have a link where it is caused by accumulation of tau. So it is important even when we do the silver staining. However, our confirmatories, though not commonly used in our labs, it is left for research purposes. It is the immunohistochemistry. So in research, we use the antibodies against the phosphorylated tau proteins and the amyloid beta protein. This is to confirm, because differential diagnosis of Alzheimer's, there are a lot of the frontotemporal lobar degeneration. It will have tau protein positive. You differentiate it by the characteristic of the amyloid beta, because the other tauopathies do not have amyloid beta, which is, as well as with Parkinson's disease, somebody would think of the multiple system atrophy, where it also presents with alpha-synuclein positive. The antibody will be positive. So how do you differentiate those two? By doing a tau protein, which will be positive now in the Parkinson's disease with Lewy body dementia. So this is what you will see on our brain. If you have seen a normal brain, you will see that the sulci, the gyri, they are different. So the sulci here are widened and then the gyri are narrowed. But you can see that the cerebellum is normal. So this is more in the Alzheimer's disease. And what do we see on our histology when we go into our microscope with our normal stains, what we call H&E, the routine stain? We see what we call the tau tangles. Yes, that is the tau tangle. And what do we see on our silver staining to confirm that is the tau tangle? And this is the plaque. This is what I was calling the amyloid deposition of Congo red staining. That's still histology. And of course, when we go into immunohistochemistry, we are doing an antibody against amyloid beta. We are looking for those plaques. So all immunohistochemistries, they turn brown for the positivity. And of course, here is another immunohistochemistry. This is with the tau, where we are looking at this is a tangle. in the neurons, and this is a plaque. And of course, in Parkinson's disease, what I was talking about, the substantia nigra, we know this is the dopaminergic area, the area where we have the dopaminergic neurons, and here the difference is that it is paired. So this, on grossly, you can suspect the Parkinson's disease, dementia. And of course, when you go into our histology, we are looking at Lewy bodies. So our Lewy bodies are usually, they stain more pinkish. We have many terms we use in our labs there. Some people may want to say eosinophilic, confuse the definition. But otherwise, those are the positions there. They are like tiny balls in here. And of course, these are macrophages that have also taken up the staining. When we do our immunohistochemistry, this is with alpha-synuclein. So we are still seeing the Lewy bodies that are reacting to the alpha-synuclein. So these small lines that are brownish, these are what we call the neuritis, the Lewy neuritis. So, in summary, when do we need the pathologist? Yes. Or why do we need the pathologist? Like we said, we have early onset dementia, that is before 65 years. You have late onset dementia. But early onset dementia will not show a lot of symptoms for you to detect them clinically. So before the family comes and says there was some witchcraft, somebody is against us, someone is against us, you need the pathologist to help you do a neuropathologic examination, which involves a postmortem and involves histology. Yes, we can also need the pathologist when we want to confirm a patient has come in and is below 65, we think they have dementia. So there are studies that have been done in the UK that have proven that with CSF analysis, you will have these proteins present, the tau, the amyloid beta. But this only differentiates between the Alzheimer disease and the non-Alzheimer disease. So you cannot still tell if it is another type of dementia. But caution is that that person should not have symptoms of dementia, because everyone who has the symptoms of dementia, they will have those proteins present. So you may not even be able to detect whether these people have just got the dementia now or it was there before. So still, the CSF analysis is not yet proven to be used. It has not yet been approved to be used regularly in our diagnosis. So postmortem is
the gold standard.
Yes. And then, like we said, the physicians, everyone caring for these patients is worried about the other medicines that you are giving our patients. But for us, we are also worried about the comorbidities, because more researches have been done and have proven that these patients die of the comorbidities than the dementia. So if you manage very well the comorbidities, so this is when you need the pathologist in research. So when you give us those bodies, we can be able to even advise you and say, no, a person died of pneumonia. And of course, some of you don't like it when we tell you they died of pneumonia, not dementia. But we have seen that the effect of pneumonia was there. So, in short, those were my references.